Today, we are going to discuss a very important and high-yield clinical topic called hepatorenal syndrome, commonly abbreviated as HRS, through a step-by-step clinical case presentation. Hepatorenal syndrome is a severe and potentially life-threatening complication seen in patients with advanced liver disease, especially liver cirrhosis. It represents functional renal failure occurring in the setting of severe hepatic dysfunction without any major structural abnormality in the kidneys themselves. In simple words, the kidneys become severely hypoperfused and stop functioning properly because of advanced liver disease and circulatory disturbances, even though the kidneys may appear structurally normal. This condition carries a very poor prognosis if not recognized and treated early, making it extremely important for clinicians to understand the presentation, pathophysiology, investigations, and management. Let us begin with the patient details shown in this clinical case sheet. We have a 55-year-old male patient with a known history of chronic liver cirrhosis. The image suggests that the patient may have had alcoholic liver disease or viral hepatitis as the underlying cause of cirrhosis. He has had multiple previous hospital admissions for ascites, which already indicates decompensated chronic liver disease. The patient also has a recent history of spontaneous bacterial peritonitis, commonly known as SBP, which is a well-known precipitating factor for hepatorenal syndrome. Importantly, there is no history of nephrotoxic drug use and no prior chronic kidney disease, which helps us differentiate HRS from intrinsic renal pathology. These background details are extremely important because hepatorenal syndrome usually develops in patients with advanced cirrhosis and portal hypertension after a triggering event, such as infection, gastrointestinal bleeding, excessive diuretics, or large-volume paracentesis without albumin replacement. Now let us look at the presenting complaints. The patient presents with progressive oliguria, meaning progressively reduced urine output. This is one of the hallmark symptoms of worsening renal perfusion. He also has abdominal distension due to massive ascites, jaundice indicating severe hepatic dysfunction, confusion suggestive of hepatic encephalopathy, and generalized muscle wasting with fatigue, which are features of chronic liver disease and poor nutritional status. The confusion occurs because the failing liver cannot detoxify ammonia and other toxic metabolites, allowing them to accumulate and affect brain function. As liver failure worsens, circulatory dysfunction also progresses, eventually compromising renal blood flow and precipitating hepatorenal syndrome. The past medical history further strengthens the diagnosis. Long-standing cirrhosis is the most important risk factor for HRS. Repeated episodes of ascites indicate persistent portal hypertension and splanchnic vasodilation. The recent spontaneous bacterial peritonitis is highly significant because infections often trigger circulatory collapse in cirrhotic patients. Interestingly, despite severe renal dysfunction, the patient has no previous chronic kidney disease, which is characteristic of HRS because the kidneys themselves are structurally intact initially. This distinction is clinically important because HRS is considered a functional renal failure rather than primary intrinsic renal disease. On general examination, several classical findings of chronic liver disease are visible. The patient has scleral icterus due to elevated bilirubin levels. There is gross ascites causing abdominal distension, pedal edema due to hypoalbuminemia and fluid retention, and asterixis, which is the characteristic flapping tremor seen in hepatic encephalopathy. Tachycardia may be present because cirrhotic patients often develop a hyperdynamic circulatory state. Blood pressure may be low or borderline because systemic vasodilation reduces effective arterial blood volume despite fluid overload. This paradox of having generalized edema and ascites while simultaneously having reduced effective circulatory volume is central to understanding hepatorenal syndrome. Now let us move into the core pathophysiology and mechanism of hepatorenal syndrome, which is one of the most important concepts in this image. The process begins with advanced liver cirrhosis leading to portal hypertension. As portal pressure increases, profound vasodilation occurs within the splanchnic circulation, which refers to the blood vessels supplying the gastrointestinal organs. This vasodilation is mediated by substances such as nitric oxide. Because a large amount of blood pools within the dilated splanchnic vessels, the effective arterial blood volume decreases even though the total body fluid volume is increased. In response, the body activates multiple compensatory vasoconstrictor systems, including the renin-angiotensin-aldosterone system, sympathetic nervous system, and antidiuretic hormone release. Initially, these mechanisms attempt to maintain blood pressure and organ perfusion. However, over time, intense renal vasoconstriction develops in an attempt to preserve systemic circulation. This severe renal vasoconstriction markedly reduces glomerular filtration rate, leading to progressive renal failure. So essentially, hepatorenal syndrome results from advanced circulatory dysfunction caused by liver failure rather than direct kidney damage. The image also highlights type 1 and type 2 hepatorenal syndrome. Type 1 HRS, now more commonly called HRS-AKI, is acute and rapidly progressive, with severe deterioration in kidney function occurring over days to weeks. It often follows precipitating events such as infection or gastrointestinal bleeding, and carries a very poor prognosis if untreated. Type 2 HRS is more chronic and slowly progressive, usually associated with refractory ascites. Although slower in progression, it still significantly worsens morbidity and mortality. Now let us examine the systemic examination findings shown in this case. On abdominal examination, the liver may feel firm and shrunken depending on the stage of cirrhosis, while splenomegaly may occur because of portal hypertension. Neurologically, the patient demonstrates hepatic encephalopathy, which in this case is described as grade II encephalopathy, presenting with confusion and altered mental status. Renal findings include severe oliguria, often less than 400 milliliters per day. Acidic fluid analysis demonstrates a high serum ascites albumin gradient, commonly called high SOG ascites, which is characteristic of portal hypertension. Importantly, the polymorphonuclear cell count may be low if active infection has resolved. Cardiovascular examination may reveal low normal blood pressure and tachycardia because of systemic vasodilation and reduced effective arterial circulation. The investigations in this case strongly support the diagnosis of hepatorenal syndrome. Liver function tests show elevated bilirubin, low serum albumin, and prolonged INR, all indicating severe hepatic dysfunction and impaired synthetic function of the liver. Renal function tests reveal elevated serum creatinine and reduced glomerular filtration rate. One important laboratory clue in HRS is very low urine sodium, often less than 10 millimoles per liter, because the kidneys avidly retain sodium in response to perceived hypovolemia. Urine output is markedly reduced, but urine sediment remains relatively normal because there is no intrinsic renal structural damage. Imaging studies, such as ultrasound, show features of cirrhosis and massive ascites, while the kidneys appear structurally normal in size and morphology. Now let us discuss management, which is extremely important because hepatorenal syndrome carries a very high mortality if left untreated. The first step is treating precipitating factors such as infections, gastrointestinal bleeding, or dehydration. Intravenous albumin is administered for plasma volume expansion because albumin helps improve effective circulatory volume and reduce circulatory dysfunction. Vasoconstrictor therapy is the cornerstone of treatment. Drugs such as Terlipressin are commonly used because they constrict splanchnic vessels, thereby redirecting blood toward systemic circulation and improving renal perfusion. In places where Terlipressin is unavailable, combinations such as midodrine and octreotide may be used. Careful fluid management is essential because these patients are extremely fragile and prone to fluid overload as well as worsening hypotension. For severe cases, advanced interventions may be required. Intensive care monitoring may become necessary in critically ill patients. TIPS, or transjugular intrahepatic portosystemic shunt, can sometimes reduce portal hypertension and improve renal perfusion in selected patients. Renal replacement therapy, including dialysis, may be needed for severe metabolic disturbances or refractory renal failure. However, It is important to remember that dialysis alone does not correct the underlying circulatory dysfunction. The definitive treatment for hepatorenal syndrome is liver transplantation, because correcting liver failure reverses the pathological process driving renal vasoconstriction. Therefore, early transplant evaluation is crucial in eligible patients.